Okay, everyone, we are now live. You can begin when you're ready.
Thank you. Welcome back, everybody. I'll ask the clerk to rise and report, please.
Thank you, Warden Marriott. Good morning, everybody. County Council met in closed session this morning between 9 and 9:28 a.m. to approve its minutes of closed session minutes of February 3rd, 2021 and March 3rd, 2021. In addition to that, it received correspondence pertaining to labor relations, personnel matters, and discussed the same. That's all I have to report.
Thank you. If Dr. Ranade is standing by, there he comes. Good morning, Dr. Ranade. Some news again this morning from the province, so I'll let you go into your report as soon as you're ready, Dr. Ranade.
Okay, thank you, Warden. I'll just confirm that you can hear me. Okay,
Perfect.
Great, thanks. There's a lot happening, and so I'll try, as I always do, to structure it into some boxes that we can talk about. And so I think the key boxes really are what's going on locally with cases and outbreaks and that sort of situation, what's going on locally in terms of vaccines, and then what's going on sort of provincially across the health system and the implications for us in terms of public health restrictions and measures. So I think those are probably the three areas that we need to have some information sharing and dialogue around. So in terms of cases, I would say that, overall, we're now, as of yesterday, reporting 2,936 cases in total of COVID-19 over this pandemic. Locally, though, in general, over the last few weeks, our case counts are coming down. Our 7-day average of cases is coming down. That's probably in large part due to a few things: increased restrictions, also the fact that people can be outside more, and also I think people are seeing amounts of community transmission and variants that are concerning enough to cause them to, reinforce behaviors that they were undertaking before in terms of staying away from each other and limiting their social and other interactions. At the moment, as of yesterday, we had 4 institutional outbreaks, 4 workplace outbreaks, and 3 school outbreaks. But all of these outbreaks in general, with one exception, had have very small numbers of cases. And so we're not seeing this sort of overrun of cases in these different outbreaks. There's one outbreak that I wanted to highlight for you that many of you might be aware of, but just in case you're not, there's one institutional residential facility that has a number of COVID cases associated with it in residence. And many, if not all of those residents are considered to be fully vaccinated with 2 full doses of vaccine on board. And so I think what we're actively watching for is what are the outcomes of that outbreak, right? Because we know that these vaccines are very effective at reducing the incidence of severe disease and hospitalization and death. And I think there's emerging evidence that the vaccines are also helpful at reducing transmission, but it's not, it's certainly not as confident or as robust as the evidence around reduction of severe disease and hospitalization. So what we're really looking for out of this outbreak is to see that there's fewer severe cases here, and that if the symptoms are very manageable, that will help to set the kind of the expectations around what other outbreaks could look like if most of the residents or all of them are fully vaccinated for COVID. So we can't really make more, statements about that until that outbreak is over. But I think certainly once it is, then we can look back at it and say what were the outcomes and how translatable do we think that will be to future outbreaks of this kind. At the moment, as of yesterday, we've had 2,725 recoveries from disease. And so I think what I would call our caseload now, it's not a technical term, but it's a very manageable caseload, and the cases are sort of grumbling along. They're moving at a rate that's manageable. We can manage contact tracing and transmission, transmission control among the cases that we identify. And they're certainly coming down over the last few weeks, which is an encouraging sign. Having said that, when I get in a minute to talking about the province, that's not necessarily the picture at the province, and so we'll talk about that in a second. if I just move on to the vaccine piece, so I'll tell you a few things around that. As of today, and our website will be updated with this information today, but we will have given 28,495 doses. So just under 28,500 doses, and many of them, most of them, in fact, are first doses. So, based on our counts and our understanding of the eligible population, we think that that represents 25% of the eligible population covered with at least one dose of vaccine. That's pretty good. Obviously, as more vaccines roll in, we will be able to do more with them. And so what we're seeing now is, just for your awareness, the next couple of weeks, there's a little bit of a dip in terms of our vaccine allocation. So we're a little bit stretched thinly, but hoping to recover or rebound from that in a couple of weeks. And it's not a local dip, it's a province-wide dip in all of the allocations. Remember that the supply chain is complex, right? It comes from wherever it's manufactured through to Canada, then it's distributed to the provinces, then to us, and then we use it. And so any interruptions along any of those pieces can cause transient delays in the supply. Right now, what we're doing is dealing with 3 vaccines primarily. So there is Moderna and Pfizer, which you're familiar with now because we've been using them for a while, and AstraZeneca, which is a newly onboarded vaccine in our community. So we think there are about 3 pharmacies now that I think have received their allotments of AstraZeneca from the province, and will be managing the distribution of that by themselves. So they're going to have their own booking systems, and the eligible grouping for that is people over 55 right now. And also, we're going to be hoping to use some of that AstraZeneca as well in primary care practices, and also for some mobile uses. And I think I've talked about that before, that fridge stable vaccines like AstraZeneca are easier to move. And so they're easier to deliver to populations through a syringe, as opposed to having to have people come to that. So we're hoping to use some of that AstraZeneca for mobile uses, or for people who can't leave to attend a clinic, right? And so I would say that all of that is going fairly well. We have a lot of, delivery models and methods, and also a lot of partnerships that we're working with in order to make all of that happen. And then I'll just pause and talk briefly about the AstraZeneca vaccine. And so I think you're aware that there's been a couple of things going on with that around the world. And so there are, now this thinking that there's a rare complication due to the vaccine, which is the formation of severe blood clots. That happens incredibly rarely. Our regulator has taken a pause with that while they evaluate, well, not our regulator, it's still regulated for the indication that it's been approved for, but the Advisory Committee on Immunization has recommended a pause on delivering the vaccine to people under 55, while they evaluate whether the risk that we're talking about here is a 1 in a million risk or a 1 in a 100,000 risk. Remember that those are both still fairly rare outcomes, but it's a question of whether this outcome is extremely rare or whether it's very rare. And that might have some policy implications for who should receive the vaccine once they can clear up that data. I think it's important to remember with respect to AstraZeneca that, for example, in the UK, they've used 18 million doses of AstraZeneca, and the incidence of this complication has been found in about 30, and not all of those 30 have been tied to the vaccine. They just know of this complication in people who've recently received the vaccine. The other problem with that is that, if you don't have enough cases, it becomes very challenging to assess whether or not this is due to the vaccine or just a normal thing that might have happened to a person, because as you get older, the incidence of clots increases. So they're going to look at all that information, and we're going to see more information come out of it in the coming days. At the moment, I don't have concerns about using AstraZeneca in the over 55 population, because the data is not showing that there are that incidence of that rare complication in that population. But we'll have to wait and see for further eligibility or further opening up of that recommendation. And I think that might even be coming up this week as they've had a chance to look at the data. And as we go through it, I'm happy to talk more about that once we learn more from the regulators and from these different countries. But in principle, has been given to millions of people very safely and very effectively. So that's important to know. And so finally, I think the third thing I want to have a conversation about or dialogue with you on was the situation about what's happening in the province and how that impacts us locally. So, several thousands of cases a day are being reported at the level of the province. That is trending upward. And I think that so the province is probably concerned about a few things. One is the emergence of variants that are more transmissible, and with respect to at least one of them can cause some more severe disease in younger populations. So that's a concern. Remember, when you think about that concern, that there's an already low risk of severe hospitalization and death in that age group. And so it's being slightly increased by the presence of the variant, but it is still quite a low risk in that age group, but there's an increased risk if you get exposed to that variant. Now, the other piece, though, is that remember that the health system has a set and finite amount of resources, right? There's a set amount of ventilators, a set amount of ICU beds, and very, very, different abilities to expand on that across the province. But in some sense, what we're hearing is that there's a push on ICU beds in the GTA area, which is causing a, pressure down the line through the system towards other metropolitan areas that have ICUs. So far, we're okay locally from what I understand, but as London and Windsor feel more pressure on their ICU beds, we will also certainly feel pressure, not just to take patients from those places, but back, but also the pressure about the inability to escalate cases to higher centers of care, to tertiary centers of care, because they're full or backed up with cases from other places. So that's the other concern. And so as the warden mentioned, you're hearing a lot about a potential stay-at-home order that might be issued later, today for tonight or today for tomorrow. I don't have any specific details on that, so that's something we're all going to have to wait for at an announcement coming today. And then, as we always do, roll with that, learn from it, try to communicate it out as soon as it comes out, and help answer people's questions about it. But I don't have any precursor information to share with you about that. Now, if a stay-at-home order is issued, it also looks like it'll be wider than the restrictions that are in just gray. I would say we've been moving through gray in a manner that has actually brought down our cases, and I'm comfortable with where our cases sit now. But if you look at the level of the province, that's not the case everywhere, and so we'll have to wait for that announcement. But if it comes, I guess probably just to preempt a later discussion that you might have on this matter, what I would say is, and I'm going to return to something I've said before, which is that I think at the level of the provincial government, that is a level of government that has both the carrot and the stick, right? That is to say that they can both intervene in a way that restricts and reduces disease transmission, but they can also intervene in ways that can mitigate the negative effects of that earlier intervention, which is something that other levels of government may not have as access to the similar policy tools that can actually do both, which is to intervene and then also mitigate the harms of that intervention. So I will, I think I'll leave it there. That's probably been a lot, and thanks for listening.
Thank you, Dr. Ranade. Councillor Stark has a question, and then Councillor Bird.
Two questions for the doctor. The first is, has the gray designation, in your opinion, had a positive or a negative effect, net negative or positive effect on our coping with COVID-19?
Wow. Okay. I don't think that there's one answer to that question. I think that really depends on who you're going to ask. I would say in terms of COVID disease transmission, the fact that we have had a reduction in our 7-day average, I'm gonna show you something and see if this helps. I'm going to see if I can share my screen with you. I don't know if it'll let me, but let me just see if I can do that. Can you see my screen? Yes. You can. Okay, good. So if you think about the different waves, and I don't have a firm, bar here that would tell us when we went into lockdowns or when things happen, but you can see a clear correlation between increased restrictions on the activities that people can do and declining case counts. And that's exactly what we're seeing here again, right? So you see cases are rising, and now somewhere around here we've been in gray, and over time that has an effect of reducing cases, right? So I think you can say from a disease transmission, I'm going to stop sharing my screen so you can see me. Can you see me? You can see me. Okay. So I think you can say, reasonably from the effect of disease transmission, that interventions that keep people away from each other and restrict the number of social and intentional proximity that they can have with each other can reduce cases, right? But we also know very clearly that on the flip side of that, there are impacts such as impacts to businesses, impacts to people's social and mental well-being and physical well-being that are not captured in the data on just the numbers of COVID-19, right? So it's hard for me to say on balance whether or not these measures have been effective at overall well-being, because we don't have great data on that. I can say from the perspective of COVID transmission that restrictions that keep people away from each other help to reduce community transmission. And that helps to keep disease away from people who might have severe illness, and that helps to keep people out of the hospital. So it's that chain that is really being impacted by these interventions.
Councillor Stark, follow up?
Yes, Doctor, recognizing that at the county level, we have no jurisdiction on the imposition of restrictions. In your opinion, should we as a county be attempting to influence upper levels to reduce the restrictions?
So I think I need to separate the two pieces. I would say on one side, at any point in time, council is welcome to advocate to the province for what you think needs to happen locally or what you think needs to happen across the province, right? So at any time you can do that. From the perspective of disease transmission, would it be advisable to recommend a reduction of restrictions at this moment? I would say probably not, given what the province is facing in terms of the case counts and the pressure on the ICU beds, right? The question that comes naturally second to that is it reasonable to have different restrictions in different parts of the province? That is to say, if our numbers are okay, is it okay for us to be in something like gray or red while other people are in a full stay-at-home shutdown? And I would say two things about that. One, if that is significantly different between two neighboring places, you are going to see traffic between one and the other. And that traffic has the potential to increase the cases in the other place over time. But the other thing I would say is that the longer that this goes on, the more apparent it becomes to me that, irrespective of vaccines, we need a more sustainable way out of this problem, right? And I don't think that sustainable way is to yo-yo back and forth between complete freedoms and complete restrictions. And I don't think that anybody has actually figured out, and I'm not saying this just as us, I'm not even saying this as Ontario, I'm saying, across the world, I don't think anybody has figured out really what is that sustainable path through this. And so everybody is now, you're seeing France, you're seeing places like that had a handle on it for a while, and now they're shutting everything down again, right? Similarly, you're seeing places that had shut down for many, many months, that are islands or whatever, being able to open things up again because they have so few cases. And so nobody has figured out a way to sort of stay the course through this and find an acceptable level of disease transmission and also an acceptable level of social or whatever, societal activity. So I think nobody has figured this out clearly. I think what we're doing, but the longer we go back and forth like this, the harder it becomes to continue.
Councillor Bird, you had a question?
Thank you, Warden Marriott. Through the chair to Dr. Ranade. Good morning. I have a couple of comments and questions for you, please. So the first one, you'll remember that a few months ago, I asked you about how the seniors were being helped before deciding whether or not to have the vaccination, especially if they had no family members or friends to help them. And you said they were all fully informed, that everything was explained to them before signing the screening and consent form, right? So since then, I've taken a look at this screening and consent form, and I have some concerns. It's quite long, and a couple of the questions are asking if they have allergic reactions to polyethylene glycol or polysorbate. So if the individual wasn't familiar with those names, didn't know if they'd ever ingested them before, and therefore didn't know if they would be allergic to them, would you decline their vaccination request?
No, so what happens when people come up to our clinics is that we always have the ability for them to consult with somebody. And so if they've come and they've said, you know what, I'm not really sure what this means, or how would I know if I had this kind of allergy, we have a mechanism for them to consult with somebody before they receive the vaccine. And that way they can have a conversation to say, I don't know what this means, or I'm worried about this. And then afterwards, if they decide to go ahead and have the vaccine, as long as they remain eligible, so then we would offer them the vaccine. If they share with us information, for example, that makes them ineligible. So if they say, I have a known allergy to this component in the vaccine, then we wouldn't give them the vaccine, but that would just make sense based on the current indications for the vaccine. But there is an opportunity for people to consult with somebody when they come to the clinic to say, I'm just not sure about this, or I have questions. And so we've been fielding a lot of those, especially with respect to people who are on specific kind of treatments or specific therapies and are not sure if the vaccine would affect that, or if the therapy would affect the vaccine. And so we offer that to everybody if they ask for it, if they come through the door.
Okay, thank you. And the second question, comments. This screening consent form mentions there can be side effects, but it does not say what those side effects are. It only mentions the items in which polyethylene glycol and polysorbate are included as ingredients. It also doesn't mention the levels at which toxicity occurs in the human body. So without knowing the percentage ingredient in the vaccine, it would be impossible, I think, to make a fully informed decision. So even if the side effects are rare, why is no mention made on this form of what the side effects are, so that those considering having a vaccination are made fully aware of this beforehand?
Yeah, so I think in terms of the consent form, it does place a certain onus on the person who is receiving the vaccine to link to the other sources of information. So we have a bunch of resources on our site, but there are two that I would highlight. One is that the province has prepared like a fact sheet that is linked through that consent form about what are the possible side effects and what, so that's one piece of that. And then also when we're asking people, or when we're offering them the vaccine, many times that question just naturally comes up, and then we can share that information with them in person rather than, if they haven't gotten it through looking through these resources. The other side of that is in terms of the actual ingredients that are in the vaccine. That's also listed in that patient fact sheet that the province has created, but it's also in the publicly available product monograph of the vaccine, and we encourage people to look at that as well. Recognize that when we look at these vaccines, the ingredients in them are actually fairly simple. So the mRNA vaccines have the mRNA itself. They have a little bit of fat that helps the mRNA move into cells. They have water. They have this polyethylene glycol, which is a known ingredient in a couple of other interventions. So essentially, if you've had a colonoscopy or bowel surgery and you've had to do prep for that, it's in that. And so we ask people questions about whether they've had reactions to other similar things. But ultimately, there aren't a lot of preservatives, there aren't a lot of common allergens like latex and things in these vaccines. So, but having said that, the information is out there if people want to look into it. So those are the sources.
So thank you. So how about the people, like you say, that there's links and that presumably you need a computer, but how about people in long-term care that do not have this access? I mean, how do they get all these questions answered? Because they probably wouldn't, a lot of them are fearful and don't like to ask questions of people in white coats. It's the old line. So what happens with these individuals?
Yeah, so I would just say that long-term care in some ways is easier for these folks to get access to the information because they can get it from us when we come to vaccinate, but also from their routine caregivers. So when they ask somebody in the long-term care home, they have a director of care, they have a medical director, they have these people who are providing them care that they can ask questions about the vaccine to, and those people also know where to get the resources to provide them the information that they need. So that's one mechanism. The other mechanism, of course, is when we're actually in there delivering vaccines, we can answer questions for them as they have them.
Okay, thank you.
Okay, Councillor Bradley, please.
Yes, Doctor, thank you. Can you give us a snapshot in the next week to 10 days of the number of people registered for the vaccine? And I realize you've opened up the gates this morning again, versus the amount of vaccine supply that you believe you'll have in the next week to 10 days?
It's a rough estimate from my memory. So, but I think that we were expecting, around, it's usually around 3,500 doses of one of the vaccines, but I think that was going to be 2,800 or 2,500 this week. And then the Moderna, we were going to get another shipment, but that's been delayed to next week. So I would say, what we're trying to do is match the clinic numbers to the allocations that we know for sure that we're going to receive. And then as we get further information on getting more allocations, then we try to open up more spots. So it's always a fluid kind of balance. That's probably the best I can do for now in terms of the numbers, but I think I would say we routinely weekly expect shipments, and then we also try to move down through those shipments as quickly as possible, but keeping a small reserve so that we know that if a shipment doesn't come in time, we can still run the next clinic.
Okay, thank you.
Okay, couple more questions. Councillor White, please.
Thank you, Ward Marriott. Dr. Ranade, are there any instances where vaccines are going to waste in our community? Are people canceling appointments or I'll just leave it at that.
Yeah.
Are you filling in the gaps if you find yourself with extra doses, and if so, how?
So far, no. So far, we're really in a situation where the people who are booking appointments want that vaccine, they're coming for it. I mean, we've not really had lots of no-shows, and I think you wouldn't expect to get a lot of no-shows until we move into different age groups of the population. And so right now, we're not in that age group. We're in the age group of the population that actually shows up the day before to make sure they know where they're going and that, they're coming to that appointment. But what I would say is all of the clinics have a plan for what to do with additional doses that might be left over in a vial at the end of the day. And so we've got different priority groups that we're accessing to get people vaccinated as additional doses come up. It's usually on the order of like 1 to 2 in any given clinic, because out of a vial you're trying to get as many as you can. The other thing I just want you to be aware of is that there are lots of different ways to measure wastage, and the traditional sense of wastage, like spoilage, things like that, we haven't had a lot of. Where you can get waste, like it's a number that counts as wastage, but I mean, I don't consider it wasted, is that you don't get enough doses out of a vial. So if you're, sometimes you have a 5 vial dose and you can only get 4 doses out of it, or you have a 10 vial dose and you can only get 9 doses out of it. And that's really a manufacturing issue for the most part, and occasionally a practice issue, but rarely. So we have to count that as wastage, but it doesn't always mean that it was really a wasted dose. Like if you couldn't get that dose out of the vial, it was not really there to begin with, but we have to count it as wasted. Similarly, sometimes you get an extra dose out of a vial, and that's like, it's not wasted, but it's sort of this surplus that you weren't expecting. So anyway, I'll leave that there. But in general, no, people are showing up for their appointments, which is great, and we always have a plan for what to do with the few extra doses at the end of the day.
Councillor Rumboats?
Yes, I was wondering, Dr. Ranade, can you speak to the hospitalizations locally of COVID cases? Like, what's happening within our own ICUs?
So the latest that I heard, and I think it was sort of yesterday, was that our ICUs are okay. They're doing all right. We're not experiencing the same pressures as the GTA. Where they are concerned is as they see pressure in the GTA move to other tertiary care centers, London, Windsor, etc., that could put back pressure on us, our inability to refer people out for more specialized care and that kind of thing. So, but so far locally, I believe the picture is okay. They're doing all right. They haven't had to open up, their COVID wings or anything like that, right? So.
Okay, it is 10:05. I'll take one more question if there is one. Otherwise, we'll let Dr. Ranade get on with his day. Oh, Councillor Napper, please.
Yes, in what way are you using that rapid testing? I had one of those the other day. Are you utilizing that to its fullest advantage?
It's a good question. It's hard to say what its fullest advantage is, okay? So remember that the rapid testing is not for diagnostic purposes, but for screening purposes. So there are different kinds of tests and you use them for different reasons. Rapid tests have been rolled out in lots of different places, for example, in long-term care homes to do rapid screening of staff, visitors, etc., right? And the recent science table kind of evaluation of that suggested that all of that rapid testing of asymptomatic people in long-term care homes has been responsible for about finding 0.16% of cases. The positivity rate of those tests was 0.16, which ends up meaning that you use quite a lot of tests on a lot of people who have no symptoms to not actually detect a lot of disease. So in terms of using that test to its greatest potential, I think people are still figuring out what that is and how it could be used. I know it's being offered through the school system on a rotating basis for parents and students, but just I would remind everyone that is, in principle, it's a very low yield test. You use a lot of resources to get those outcomes, and knowing that, so that's what we're finding there. So there's even a question about how frequently should they be used in different settings if we're not getting the output or the yield that we think we need to from it. So I would say it's an ongoing discussion about how best to use those tests.
Okay. Seeing no other questions, thank you for that update, Dr. Ranade. And we'll let you continue with your day. Thank you.
Okay, thank you, everyone.
I would look to have a motion to allow delegations today. Moved by Councillor Wheeler, seconded by Councillor Cook. All in favor? It's carried. First delegation is Brian McDougall, General Manager, St. Clair Conservation Authority. I've seen Brian earlier. I'm sure he's standing by.
I am indeed Warden Marriott. For whatever reason, I can't seem to start my video. Maybe Carly has to do that.
I seen you earlier, Brian, so there you go.
I also have Brian Horner, the General Manager from Asaba Bayfield Conservation Authority with me. We were asked to have do a short presentation today, more or less as an update, very glad to have most of you who I've had a chance to work with in the past, either on our board or on projects, etc. And I know Brian the same way. Thank you very much for inviting us to speak to you today. If I may, Warden Marriott, do you just want me to carry on?
Yes, please. And thank you for introducing Brian Horner. He was on the introduction list and I failed to do that. So thank you.
Problem. Not a problem. I'm going to do my best here to share my screen. And hope that everyone can see that. Is that okay for everyone? Excellent. So what we wanted to provide an update on today is basically the changes and the status of the changes to the Conservation Authorities Act. Over the last 5+ years, we've both provincial governments of the recent past have taken a closer look at conservation authorities and our act with the intent of trying to improve clarity, flexibility, ensure that we're meeting all the objectives both of the provincial government but also of our local governments. And therefore multiple changes have been enacted to our legislation. In late 2019, the County Council offered to host a consultation session with municipal councils and staff to ensure that we are bringing everyone up to speed on what those changes have been. In 2020, of course, was a far too eventful year, as the case may be. Our COVID pandemic ongoing, unfortunately, began to complicate things as far as planned provincial consultation, which went on mostly virtually as the year went on. And we had been told that as it moved forward, we would be anticipating some changes in legislation by the end of 2020. December saw the budget legislation come forward as Bill 229, and it had some accompanying changes to legislation specifically regarding the Conservation Authorities Act. And I'll maybe kind of go through these in two different pieces. The ones that have been proclaimed, so have been enacted, are as follows. And I'm not going to read everything on the screen in front of you. I'll just kind of skip through the highlights, but specifically statements regarding term limits for chair and vice chair, the potential for agricultural appointments to the board of directors, public access to agendas and minutes, appointments by municipalities to be municipal councilors rather than public appointees, the audit requirements, permitting requirements for minister zoning orders, and the removal of our ability to expropriate property. Further changes to the Act have yet to be proclaimed. These include some real true definitions of what the objects of an authority are, as well as statements about mandatory programs, municipal programs, other programs and services, or what we call watershed programs and services. There's going to be additional consultation required with our member municipalities with respect to all of these programs, and the resulting requirement will be a memorandum of understanding with each municipality on those programs and services to be carried out locally, as well as the creation of a transition plan that gets us from where we are today to having all of those MOUs signed with each of our member municipalities. Further unproclaimed items, there will be, at some point in time, a lot of appeal processes for Conservation Authority regulatory permits. So what we could refer to as our fill, construction, alteration to waterways permits type thing. There will be increased fines for permit violators. The proposal for the formation of public advisory committees to work hand in hand with our boards of directors, and several areas where the Lieutenant Governor and Council may make regulations moving forward. I've really flown through a lot of those, and certainly I understand that you have the presentations in front of you, so I don't want to take up any more of your time. Maybe just to wrap up, one of the things that was intended to result from a lot of these changes was clarity, and I guess we're still hoping that we can get to that point. At this point, I'm concerned trying to express what these changes have been, and the fairly fulsome changes that I still anticipate moving forward would be very difficult at this point for council or municipal staff to be of any value to them. And I think we had really talked about hopefully waiting to that point when we actually get these final legislative changes from the province, we'll be able to have that discussion and make sure that everyone is on the same page. There has been a working group established to kind of at the minister's direction to discuss the implementation of these additional changes. The first proclaimed changes were made in early February, and we'd very much anticipate that where we would see the second round or second phase of changes in either April or May, and then the final changes potentially as early as June. And that, of course, I suppose could be pushed back to maybe even September. but those next two phases of change to be forthcoming. If there are any questions, Brian, I would love to try and answer them for you.
Okay, I can't see everybody just yet, but any questions from council? There we go. Councilor Ferguson.
Thank you, Warden Marriott. Good morning, Mr. McDougall. Two or three observations I'd like to put in through the presentation. And people may not know there's been downloading from various ministries to the conservation authorities over the years for different projects, such as now you're involved in no-till projects, etc. So sometimes your staff can be, you need more staff because projects have been downloaded as have been cutbacks in other branches of government. At what point with permits could you work with the county to help training some of the county building inspectors, planners to give stamp of approvals to some of the simpler projects that are straightforward? Would alleviate some of your concerns. It'd be no money out of pocket and it could move ahead that way. So just a thought that could be, and if there's going to be a stickier project, yes, it goes back to your organization, but would it free up time for that? Secondly, there was, and I brought this up before several years ago, representation from the farm community, and I'll use the Ontario Federation of Agriculture, which I'm more familiar with. I would like to see somebody on the board. I see there with the minister's appointment, you can put somebody on there. The OFA does have field service representatives, and the one for this area does 2 counties. There you have, with the farm groups, you do have your largest landowners, private landowners within southwestern Ontario, which all your regulations impact. I would like to see, perhaps when you appoint somebody out of the administration side of the OFA or the other 2 farm organizations, because they have the ability to go back to the parent organizations, and they do have research people on staff to help them with different projects or different scenarios that come ahead. So that's my 2 things for this morning. Thank you for your time.
Mr. McDougall.
Thank you, Warden Marriott. Back to Councillor Ferguson. I can certainly bring both of those forward for discussion. At this point, the agricultural appointments would be specific to ministers' appointments, and I can provide this information back to the working group that is currently discussing those items with ministry staff and the minister. As far as the delivery of permitting through county staff, even at that most basic level, that's something that I can certainly discuss with both our staff and county staff. There normally is a requirement for sign off, so there would have to be some way we would get it back to having the right trained individual doing that sign off, and that might mean that county staff would require that at some point. So there's a few little hiccups that I can see, but it's certainly something that merits discussion.
Okay, Deputy Warden Hand.
Sorry, just to confirm, Mr. McDougall, and thank you for your presentation. You intend we can have a follow-up presentation when all of these final details are confirmed so that we have the clarity? Okay, thank you.
Councillor Loosley.
Yeah, thank you, Warden Marriott. Just to add on to Mayor Ferguson, I wanted to mention, I also think it would be a real good idea if, and again, Mr. McDougall, Mr. Horner, thank you for coming too, by the way, but I really like the idea of to try and speed up the permit process if the county could, take on the signing authority rather than sending it on to the conservation and delaying it. Because I know the board has basically a 15-day turnaround for permit approval, but we're not making that, which is unfortunate that it takes so long. The other thing I just want to state, and I am a board member and I understand some of these changes. I do support these changes. I think in talking to the province, it's been over 10 years they've been looking at doing this. But I think Mr. McDougall also knows my concern regarding competing things with the Drainage Act and the enclosed drainage process, that a lot of time is wasted on listening to hearings. And the idea was to simplify that, to eliminate conservation staff time to allow a little faster approval process. That's all. And I just wanted to bring that to council's for council's information. Now, I just wanted to ask too, Mr. Horner, if I could, how many people sit on your board?
We have our board. We have 9 board members. They represent 12 member municipalities. I apologize. I don't recognize a lot of faces, but I do have a couple that I know of. And our current chair, Mr. Cook, represents Lambton Shores and Warwick. And I will say shout out to our one of our former chairs, Mr. Weber. So yeah, we have 9 members on 12 member municipalities. So 3 of our members represent 2 each.
Yeah, thank you for that. And if I can ask, when was basically the last time you looked at restructuring or you restructured?
As far as our, it's probably well before my time. It would have been post amalgamation. As we probably have our former chair was probably around when that happened.
And that's fine. But I guess my concern and where I'm going with this is, Mr. McDougall, we have, is it 19 members on our board?
20.
20, thank you. And if I can, through you, Ward Marriott, Mr. McDougall, when was the last time we looked at restructuring? And my point is, it seems like a big difference from, say, 9 members to 20 members. When was the last time we looked at possibly restructuring to maybe bring the number of members down a little bit just to be more effective?
The last time that it was discussed would have been in the mid-1990s. And at that point in time, certainly with 17 member municipalities, in order to restructure, we would be looking to have single representation of multiple municipalities. And the balance, the concern being is the balance that would be shifted due to the population sizes of our larger municipalities. With Sarnia having 3 members on our board of directors and St. Clair, Strathroy-Caradoc, and Chatham-Kent having 2 members each, there'd be some concern about the balance of membership if we scaled back too much further, I believe, unless that was, again, supported locally.
Thank you.
Okay, any last questions before we wrap up? Councillor Arnold. You're on mute.
Here we go. Thank you, Ward Marriott. Just thank everyone for their presentation here this morning. And I know it's not in relationship to the Conservation Authorities Act, but I'm just wondering if you could give us about a 2-second update on algae blooms and the impact of phosphorus, et cetera, in the Great Lakes, Lake Erie, and even Lake Huron, because I know it's showing up more along Lake Huron. And Mr. Ward, if I'm out of order, just tell me, and maybe Mr. McDougall could send me an update later.
I'll give Mr. McDougall a chance to do that.
Certainly. Thank you, Mr. Warden. Councillor Arnold, this is something that we have seen a greater trend of, certainly in the immediate past. And with, I hate to say this, but this wonderful weather that we've had, the warm temperatures early like this, it is going to exacerbate that situation as far as the potential for algae blooms. There is a lot more monitoring that happens now than there has been in the past. So I think that's a good thing. So we're seeing and spotting these things more quickly. I would say, and maybe specifically tooting our own horn, the Sydenham River is going to have a phosphorus management plan that will be going out for consultation later this year. So we've also got a document that's really been able to look at specifically, even locally, where is the phosphorus coming from, how can we better manage it, etc.
Okay, Councillor Weber had a question.
Thank you. Yes, great presentations from Brian and Brian with the both conservation authorities. I would, because this is something that all the memorandums of understandings that have to be developed are with the local or the first tier municipalities. I would ask if it's possible to send this presentation to all of the municipalities so that they have this information where we stand. The other thing that I'm concerned, or I guess I do sit with AMO task force that's looking in all the different things of the Conservation Authority and all of these changes. And one of the things that's clear across the province is that one size doesn't fit all for these regulations. And the consultation group that's been set up by the province, I don't believe has any representation west of GTA, or I'm not sure where the last, it's Kitchener at least. This area of our province is not represented on that working group. So that is a concern, and I think that this would be helpful if it was sent to the lower tier municipalities so that they're aware of where we are. And there is going to be a lot of work dealing with the MOUs and how that works, and the working relationship between the county planners and the conservation authorities is going to be needed. But just a couple comments. Thank you for that.
Thank you, Councillor Weber. We'll make sure all the lower tier get this presentation somehow. Well, thank you, Mr. McDougall, Mr. Horner, for coming on today, and we'll see you when things get more settled, I guess, Brian. Thank you.
Thank you, everyone.
Thank you.
Our next delegation is Dr. Matthew Davis, the Regional Director, Medical Director for Southwestern Ontario Regional Base Hospitals Program and Emergency Physician at London Health Sciences Centre. I see Dr. Davis is on now, so
yes, thank you.
Welcome, and I'll let you start your presentation, please.
Great. Thank you for the introduction. I'm just going to share my screen here. And is that showing there for everyone? And do we, just because on my screen, I want to make sure I've got presenter notes here. Are you seeing those presenter notes or just the slides?
Yeah, we are, Dr. Davis.
Just the slides or the presenter notes too?
Both.
Both, okay. Let me take care of that. I don't want to take away from all the aesthetics of this here, so just give me a second, I will get rid of that. There we go. How's that? Slides?
Actually, no, that's makes the presentation smaller.
Smaller.
I think what we were seeing before was the next slide on the right. So.
And 1 second, let me just try to troubleshoot this here for us. Yeah.
You were correct the first time, sir.
Yeah, I think you're right, Councillor Ferguson. It was right. It's just the next slide was on the right.
All right. Are you seeing my desktop or the presentation?
I believe it's your desktop.
Okay.
I think you just need to click on your left corner and go from beginning, and that'll pop up your full slide.
It is popping up on, I've got two monitors here, so it's popping up on my other monitor here. Let's try a couple other things. These are like the nightmares, you know, you get in front of the audience and you're not wearing clothes in your dreams. This is one of my new COVID nightmares, of not getting your technology to work properly here.
There
Screen.
We go.
There we go.
There
All
we go.
right.
And we don't
All
have-
right. My other nightmare is that box that comes up that says your computer is going to automatically shut down in the next 2 minutes, and you can't help it. So, all right, sorry for that. Okay, thank you, everyone. Good morning, and as introduced, my name's Matthew Davis. I'm an emergency physician at LHSC. I completed subspecialty training in pre-hospital and transport medicine, and I'm the regional medical director for the Southwest Ontario Regional Base Hospital Program, which is quite a mouthful, so we call ourselves SWARP. And base hospitals are not a real well-known entity, but we provide medical direction and delegation to paramedics here in Ontario. We also provide leadership and advice in the provision of pre-hospital care and emergency health care in Ontario. And now my slides are not moving. Dear. My apologies, everyone. Well, I apologize. I will send the slide deck to everyone, and I can just give this presentation verbally. There are some, unfortunately, some slides that I do really need to show here. So,
Dr. Davis, we can see that slide. It's just smaller. So,
okay.
if council
Let me see.
can-
So you can see the slide, but it's a small slide.
Yeah.
It says SWARP demographics.
Yes.
Okay.
If council can see that, okay, we can here.
I can see if I can try to make it a bit larger here. There we go. Okay, let's do this. All right, I think we've got it solved. Okay, so as I said, SWARP provides medical delegation and support to 11 services here in the Southwest and over 1,400 paramedics. We also provide advice to the Ministry of Health. We develop directives, policies, and procedures related to the best medicine when it comes to pre-hospital medical care and pre-hospital systems of care. We have a medical council, so there's 4 other physicians, including myself, that sit on our medical council. And we work at various hospitals here in the Southwest, including LHSC, Grey Bruce Health Services, as well as Windsor Regional. Our team is structured in a way that we have local medical directors who provide more of the day-to-day medical direction oversight to some of our local services, as well as a medical director of education, given the large role that education plays in the world of pre-hospital medicine. We are active emergency medicine physicians, so we all practice in the emergency department. We also hold recognized medical specialties credentialed in emergency medicine. And recently, the Royal College of Physicians and Surgeons has recognized that pre-hospital medicine and transport care is such a distinct area of medicine that they now recognize this as with an area that physicians must or should have an area of focus competence diploma. In keeping with our base hospital physicians' mandate to provide the best pre-hospital care to patients in our communities, many medical directors that work at other base hospitals in the province, as well as our own base hospital, also provides medical direction and oversight to fire services. For example, Dr. Paul Bradford, who is the local medical director for Lambton County EMS, also provides medical direction and oversight to Windsor Fire. And he's helped build collaborative and seamless transition of care between fire and and paramedics. He's been able to instill joint training between paramedic and fire services, provide quality assurance on their quals, and innovative programs that are safe and provide both benefit to the firefighters and the public. So I've been asked to come today to speak about the evidence behind tiered response and what are the benefits of tiered response. And tiered response are designed to provide time-sensitive medical interventions prior to paramedic arrival. It's also developed to help aid in paramedics in scene management, extrication of patients, the ability to retrieve equipment from the ambulance too during cardiac arrest situations per se. Again, because there's only usually 2 paramedics that arrive on most medical calls. So what are some of the time-sensitive interventions? Well, fire may have faster response times than paramedics, and this can vary based on geography, day, call volumes within the city, and it's not a constant. The questions that really need to be asked is how much faster can fire arrive? How is this measured? Again, are we measuring apples to oranges or apples to apples? And the most important question is what can be done by firefighters prior to the paramedic arrival, and does this make a difference for the patient? Is there an impact on their outcomes, morbidity, or mortality? And of course, in everything medicine, we also want to look at the risk of what we're doing, because with medicine, there does come risk, and that needs to be weighed against the benefits of what we are doing. So modern medicine is guided in what we call evidence-based medicine. And modern day medical investigations, treatments, and recommendations are guided by evidence, and as we term this evidence-based medicine. And what this is we look at all the research there is about a disease or treatment, and when we look at evidence, not all evidence is alike. Some evidence is better than others. But when we do, as physicians, recommend a treatment, we are using evidence-based medicine. Sometimes, the evidence can't tell you what treatment is best, so it's always important to weigh the benefits and the harms of that treatment carefully. And this is sometimes when, values often drive direction. So what is good for one person may not be good for all. So getting into the evidence for medical benefits of early response. The International Liaison Committee on Resuscitation, otherwise known as ILCOR, reviews all evidence on resuscitative care and makes recommendations that are based in evidence. These guidelines are published throughout the world by various bodies, and here in North America, they're published by the American Heart Association. And these guidelines are based on the most current and comprehensive review of resuscitation science, systems, protocols, and education. This is what drives emergency and resuscitative care throughout the world, from layperson to first responders to medical professionals. We do know that there is evidence for an early response in cardiac arrest patients. We know that early CPR increases survival. This increases survival about 30%. So the earlier chest compressions are started, the better chance patients have of survival. We know that early defibrillation is beneficial for cardiac arrest. So patients who are in a shockable rhythm, the quicker we can get a defibrillator to that patient, the higher chance they have of survival. We know for every minute that passes where a patient in a shockable rhythm goes without a shock, we know that mortality increases by 10% each minute. We also know that basic airway management plays a role in resuscitative care, and therefore airway management is also vital to be done earlier on as soon as possible. So we definitely have evidence behind cardiac arrest in early response to have someone trained to provide those services to the patients. Outside of that, there really isn't much more benefit to early arrival of healthcare responders. There is some expert opinion. As I said, not all evidence is alike, but there is expert opinion that for patients who are choking, that early response is beneficial. And this really leads back to the cardiac arrest situation, because when people are choking, that airway obstruction is unable to be resolved. These patients will often go into cardiac arrest. So that is an intervention that can be done, which the sooner it's done to remove that foreign body or attempt to remove that foreign body, the less chance the patient would go into cardiac arrest. There is also some expert opinion that potentially for anaphylaxis treatment, so this is outside of allergic reactions. This is life-threatening, severe allergic reactions that having first responders being there sooner may have an impact on both mortality and morbidity. Again, not a lot of evidence behind this, but this is more, expert consensus. And that's really weighed in the fact that these patients should have a history of anaphylaxis and no access to that EpiPen. Epinephrine is a dangerous medication when given inappropriately to certain patient populations and for things that may mimic anaphylaxis. So, of all pre-hospital first responder things, this is a very dangerous drug that could have certain side effects that may make actually patients worse when used inappropriately. We also know that fire is beneficial in extrication and scene management when it comes to cardiac arrest. They can provide chest compressions and basic airway management while paramedics are also performing life-saving interventions. When we look closer to home at what evidence has been generated out of Canadian systems, one key study is by Alan Craig et al. Out of Toronto. And what they sought out to do was develop a model to discover what calls fire could intervene on in order to decrease the amount of calls that fire attended, whereby they had nothing to medically offer. In this model, the calls that firefighters could intervene on really all related again to cardiac arrest, potential cardiac arrest cases. And with this model, they reduced firefighter response to about 7% of all paramedic calls. It should also be noted that with this model, firefighters were only able to intervene, actually provide an intervention in one instance out of 17 calls they do attend. So really the summary of the evidence for tiered response that time-sensitive medical benefits are really limited to cardiac arrest. There is definite benefit to having them be on calls where they can assist with extrication, CPR, airway management, and equipment retrieval. And we know this can be very valuable to patient outcomes when fire is on these cardiac arrest calls. As I alluded to earlier, in medicine, all treatments have to be weighed against risks. So it's very important from a medical standpoint to examine the risks. And there are risks to tiered response to both firefighters and the public. There is also costs to tiered response agreements that needs to be weighed against the benefit. I will focus on more of the public health aspect of the risk and stay out of the world of costs and money. So when we look at data, this data is from the National Fire Protection Association of the USA. We don't have as much robust data that I was able to retrieve or with the assistance of our LHSC librarian when it comes to Canadian data. But to kind of put things in a North American content, in 2019, the NFPA reported about 15,000 fire department vehicles that were involved in collisions, of which 8 resulted in firefighter death, and there was injuries to about more than 1,000 firefighters because of these motor vehicle collisions. And anywhere from 10 to 25% of all firefighter fatalities are related to these MVCs. But it's also important to note that civilians are also involved in these collisions, and they're actually 2.5 times more likely to be killed than a firefighter and 4 times as likely to be injured. When we look at the Canadian data, what we found was that about 9% of firefighter deaths are related to MVCs, which is the second leading cause of death for firefighters on the job. And of these cases, 70% occurred while the vehicles were lights and sirens response. But this is not an American problem. It's also a problem in Canada, a problem in Ontario. It does happen. And when you go through kind of, just a quick Google search, you do start to see stories about vehicle collisions, pedestrian struck, firefighters injured, citizens injured and killed from emergency response vehicles. We know that all emergency response vehicles are dangerous when they are responding to any type of emergent situation. So the question becomes, is it worth the risk to send fire to calls where they actually have no medical benefit at the potential cost of vehicle collisions, injuries, and death of firefighters and civilians as well in situations where medical benefit can't be offered? I think in situations where medical benefit can be offered, such as cardiac arrest, the risk may be deemed acceptable. And I think most medical directors would agree with that. However, I think from a public health perspective, it's very difficult to explain a devastating outcome when fire is responding to a call where they could not offer any medical benefit, especially when current evidence shows that there are a lot of calls that fire may go to where they cannot offer any benefit to that call. I think it's also important to note that in 2015, the OPFFA put together a proposal that looked at having paramedics on fire vehicles, and they wanted to perform symptom relief as part of their first response to certain medical calls. And this really makes up the core of paramedic interventions, these medications such as aspirin, glucose, Ventolin, nitroglycerin. There was a lot of opposition to this proposal. The Ontario-based hospital group of medical directors, of which I'm one of 7, had significant concerns with the patient safety and the lack of benefit to this proposal. And I think there were a lot of other professional groups and stakeholders with similar concerns. And in our opinion, in order to achieve the most benefit for the patient while balancing the risk of treatment, these skills should only be performed by fully certified paramedics in the pre-hospital setting. Paramedics have 2 years of college training focused on this type of intervention. They're moving to a 3-year program because of the increasing scope of pre-hospital medicine and the knowledge base that has grown. Furthermore, there's such tight regulatory oversight of paramedics. They're highly trained to provide this care. And because of that highly trained care, as well as that regulation that is oversees paramedics, this allows for paramedic safety. So medical evidence does exist to support the use of tiered responses, but it's very limited to a specific group of patient complaints and problems. And these are all patient complaints and problems that may be mimicking cardiac arrest. So your unresponsive patients, your unconscious patients, your patients who are not breathing, your pulseless patients. Extending responses outside of this specific group provides no additional medical benefit. There is potential for patient harm. It's often thought that something like oxygen is harmless, but in fact, oxygen applied to the wrong patients can actually cause harm. And we have learned that not all oxygen is beneficial to patients. It also, as I mentioned, exposes responders and public to risk of harm without any recognizable benefit, and also adds costs to the system. As medical directors leading Ontario-based hospital programs, we're privileged to work with paramedics, firefighters, and other emergency responders every day. It is our opinion that pre-hospital care is provided by highly skilled paramedics, supported by trained firefighters and first responders, as a structured and evidence-based tiered response system. So thank you for the opportunity to present some of the evidence behind tiered response and medical benefit. I'm happy to field any questions from the medical side of things.
As soon as we get ours, there we go. Any questions for Dr. Davis? Councillor Bradley and then Councillor Stark.
Yeah, Doctor, thanks for the presentation. Your organization, are you paid to make this type of presentation? Are you a lobby group, or what are you? And then I have a follow-up question.
So we are funded by the Ministry of Health. We have a performance agreement with the Ministry of Health. And as part of that performance agreement, we are required to provide medical advice to upper tier municipalities, as well as designated delivery service agents, which are paramedic services, in pre-hospital issues and tiered response agreements. So we are here to provide advice and in this case, the evidence behind it. We are not a lobby group. Like I say, we receive our funding from the Ministry of Health and report to the Ministry of Health.
And you recognize there's dissent to your views and your position. How many?
Sorry, I didn't. Was that a question that you had there?
No, I just making this comment to you that you recognize there's dissent and opposition to some of the views you've expressed here today.
Okay.
The question is, the follow-up is, I'm sure you must have done the research if you're speaking to Lambton County Council. How many accidents have involved Sarnia fire vehicles on medical calls?
I don't have that information.
Don't you think that would be a good statistic to have to present? My information is there has not been any such incidents.
There may be no incidents, but it is a possibility. As I say, it does happen in fire services. There are other fire services in Ontario that have very similar models of fire delivery that do result in vehicle collisions, accidents, injuries, and deaths. So it is not a no. It does not happen, isn't it? It does happen and can happen. And that's when it comes down to weighing benefit versus risks. That's a judgment call. I'm here to provide evidence.
And do you have any statistics on the number of other emergency vehicles that are in accidents on the response to tiered response, whether it be police, ambulance, what their statistics are?
Just as dangerous. I don't have numbers.
Okay, thank you.
Councillor Stark.
Yes, Doctor, thank you for your presentation. I noted in the presentation that you indicated that 1 out of 17 calls, which translate to 6%, see a positive impact of fire attending at a particular call. So my question is, would you have a problem with firefighters who are attending a call who happen to be also EMT trained, and given Sarnia as an example, where we have 20 firefighters who are EMT trained, including 2 nurses in addition to that, would they be considered an asset with their presence at a scene? Thank you.
So a lot goes into the pre-hospital oversight of professional delivery of care. There's risk for skill degradation when you are not performing a skill often. And we do know that that skills decline when you're not using those skills. As such, we have intense training with paramedics to ensure that skills are maintained, which is the core focus of what they do in each and every day. So we as Base Hospital have dedicated yearly continuing medical education time with paramedics. The services also have their own education and training time with paramedics to ensure that paramedics are up to date on training, that they don't lose their skills. We also have robust quality assurance. Every cardiac arrest medical call has eyes on. We have a robust auditing system that reviews every call that is generated to look for variances from directives. This allows for us to allow for quality improvement initiatives to follow up with cases and ensure that, when variances do occur, that we meet with the paramedics and ensure that in future cases those variances don't occur.
Follow up, Councillor Stark, and then Councillor Rumboats.
Yes, Dr. Davis. So then to finally get to the point that I was asking, would you agree that if an appropriately trained and continually trained EMT or nurse would be an assistance at these calls?
No, I would not, again, because paramedics are the sole professional organization that is trained to provide this pre-hospital care from a standpoint of having paramedics working on fire services, again, for various reasons. it is my opinion as well as the Ontario-based hospital group that having paramedics staffed on fire vehicles is not necessary, again, because of the time response is only benefited to those who are in cardiac arrest. So having people who are trained as paramedics that are attending cardiac arrest calls, great. They have the skills as well as other firefighters who aren't trained as paramedics to provide those interventions that make a difference. Having someone arrive at a call 3 minutes before a paramedic really has no benefit from a medical standpoint. In fact, a lot of EMS systems are looking at, a lot of research looking at lights and sirens response and the need for lights and sirens response, especially returning to hospital, because again, from a lot of medical conditions, we know that 5 minutes, 10 minutes doesn't make a difference.
Okay, I have Councillor Rumboats and then Councillor Loosely and then Councillor White. Go ahead, Councillor.
Thank you, Warden Marriott. Dr. Davis, would your advice change in the rural communities where the response from the ambulance can sometimes be a lot longer? For example, in Watford, if there's no ambulances within, say, 20 minutes of the scene, and we have our volunteer guys that could get there sooner, would that change things at all, or would you still stick to your original?
Again, what I'm looking at this as lens through medical evidence. And again, the medical evidence would say in situations where the patient may be in cardiac arrest, yes, there's benefit to having people arrive sooner rather than later. Outside of that, again, from a medical benefit standpoint, it would not make a difference in other cases outside of the ones that I'd outlined in the presentation as to having someone there sooner rather than later.
Councillor Loosely.
Yes, thank you, Warden Marriott. I just want to thank Dr. Davis for that good presentation. I found it very informative and I needed to hear that. So thank you for that. Thank you.
You're welcome.
Councillor White.
Thank you, Warden Marriott. Dr. Davis, thank you for your presentation. I have two questions. First off, are there any indications you continually discussed risks, and I think you mostly focused on motor vehicle collisions. Could you indicate maybe some of the other risks medically to having firefighters attend a scene?
From a medical standpoint, what risks would there be? Again, it depends on what care is being provided. As I alluded to, sometimes the application of oxygen can be harmful in certain patient populations. So the thought of, if we get there and someone's having shortness of breath, well, let's give them oxygen, because oxygen is a good thing. It's in the environment. People are short of breath, they need oxygen. We know there's pathology out there where oxygen actually can be more detrimental than good for these patients. Outside of that, reading through some of the responses and documents, the ability to coach with breathing, slowing down people's breathing. Well, some pathophysiological responses require people to be breathing fast. And when that medical condition is not recognized that the person is breathing fast for a reason, and you're trying to coach them to slow their breathing down, this can actually be detrimental because the body is adapting to the medical issue going on there as well. So, medicine is difficult, and that's why we go to do an undergrad for 4 years, medical school for 4 years, and specialty train for 5 to 7 years. This is why paramedics have dedicated college programs for 2 years, which is now being increased to a 3-year program, because there are nuances to medicine that are very difficult to discern, and when people are providing care without that appropriate training, then the public is at risk.
Okay, thank you. And my second question, and certainly I will never question anybody's qualifications, no matter what. So I appreciate that. Are there any circumstances where a call may be deemed without the scope of the current recommended tiered response, and suddenly that patient may turn into a situation where it would be beneficial to have of somebody there. For example, if an ambulance is 10 minutes away, and a patient is not deemed to be within the scope of your recommended tier of response, are there instances where a patient may then suddenly lose consciousness, and then having that added service would be beneficial, but not known at the time of the call?
So again, the information would be relayed to dispatch. They often stay on the line with the callers in these situations. And when there is a deterioration of patient, I think that would be appropriate. If someone were to become unconscious or stop breathing, then yes, that would be the trigger to have a tiered response, just to have someone get to the patient as soon as possible. That would be an indication, yes.
Any further questions for Dr. Davis? Seeing none, thank you again, Dr. Davis, for giving your presentation today. And thank you very much.
Thank you for the opportunity to speak. Take care, everyone.
So, Council will be, we have this on our agenda later to discuss as well. Moving on to number 8, minutes of Council of February the 3rd. Do we have a mover? Councillor Cook, seconded by Councillor Weaver. All in favor? And that's carried. And item B is the Lambton County Council budget minutes of March the 3rd. We have a mover, Deputy Warden Hand, seconded by, who was that? Councillor Bean. Favor of that? That's carried. Number 9, correspondence. Correspondence to receive and file. We have 3 items. How do you wish to move all 3? Moved by Councillor Loosley, seconded by Councillor Miller. All in favor? That's carried. Item B is Lambton Board of Health correspondence.
Excuse me, Warden Marriott.
Yeah, go ahead, Councillor Arnold.
I was trying to get your attention. I wanted to take item B out and endorse that. For the court. If I'm too late, that's fine.
No, sorry, I should have seen that, Councillor Arnold. So
I didn't hear it.
It's a motion to lift.
Yes,
Councillor Arnold.
And to support.
Okay, seconded by Councillor Rumbouts. All in favor of that? That's carried. Did you wish to speak to that, Councillor Arnold?
Nope, I'm good at getting the support. We'll just send that back to the folks and wherever it has to go.
Okay. So item, where are we here?
So maybe take a step back, because I don't understand what he was lifting and supporting.
Yeah.
Because we're at item B, 9B, which was just the correspondence to receive and file, really.
Mr. Tifo would like to clarify that, Councillor Arnold, what you were.
It's 9A, subset B.
There you go. Okay, we got that.
Okay, thank you. So now we're at B.
Now we're at B. Yep.
Yeah. Okay, item B is Lambton Board of Health correspondence. So we have a recommendation, the following correspondence be received and filed. We have a move by Councillor Dean, second by Councillor Napper. All in favor? That's carried. And item C is correspondence from member municipalities. A is a letter from City of Sarnia. Councillor Rumbouts. Moves. Okay, thank you. Seconded by Deputy Warden Hand. All in favor? That's carried. Oh, sorry, Councillor Broad, you have a question?
Yes, I do, Kevin. The motion states it to adjust it. Does that mean adjust up or down?
I'll ask, Councillor Bradley, go ahead, please.
Yeah, Mayor Broad, if I could speak to the motion, and I don't think it's redundant because there will be a time when this newest lockdown will be finished. It was to say simply that this idea that every restaurant was given capacity for 10, whether they could take 10 or take 100 or 200. So I believe that the will of council or the direction of council would say, do like you're doing in the churches, to do it by percentage of square footage and capacity. Simply don't put a number on that. And I think the government actually started to move in that direction in the last little while.
Okay.
Clear? So all in favor of that? Oh, sorry, Councillor Arnold. It's hard to see hands this morning.
Oh, that's all right. Thank you, Ward Marriott. I'm just wondering if we could add that to the motion then, because it's not in the motion, that it be adjusted on a percentage basis.
Gotcha. That makes sense.
Okay.
That's all right with the seconder.
Yeah. Thank you for that clarification. All in favor of that? That's carried. So item 10 is items not requiring a motion. Creative County Committee minutes dated November 26th. Councillor Miller moves. Councillor Weaver seconds. All in favor? That's carried. Number 12, reports requiring a motion. Number A is Public Health Services Division.
Number 11 first, I think.
Sorry. Number 11, and information reports. Move to receive and file. Moved by Councillor Bucci, second by Councillor Cook. All in favor? That's carried. Now number 12, reports requiring a motion. Public Health Services, Emergency Medical Services Department. Councillor Bradley.
Yes, I'm going to move that this be tabled one more time for 1 month to the next county council meeting, and that the city and the county emergency services resolve this issue and come back to us.
A seconder, that's Councillor Broad. All in favor?
So, Mr. Warden, just a point of order. Is it not already tabled? Does that mean we're going to leave it tabled? Because there's a motion there of item 8 from committee. Or are we tabling number 9?
We'll be tabling number 9, and that's what we're doing. Yeah, we're tabling number 9, but by consequence, 8 gets tabled as well.
Okay, so by doing 9, 8 gets tabled as well.
Okay.
And that was all in favor of that again, please? Yeah, that was carried. So item B, long-term care division. We have a report there. We have, do I have a motion on this report? Councillor White?
Move the recommendations.
Okay, second by Councillor Arnold. Anybody wish to speak to this? Councillor Bird.
Thank you, Warden Marriott. So thank you to the staff for their report. However, I feel that the point of my carried March 3rd budget motion was to save huge amounts of money. The proposed dementia village will only serve 10 dementia residents and not the 21 as per last fall. And I'm sure that's a number that has gone up significantly by now. The costs are far too high for accommodating only 10 people. And as you say, Meadowview Villa is an old building and no longer meets the 1991 or current building codes. Yes, as you suggest, we'd be able to use certain parts of the building for affordable housing, but I don't want to see Band-Aid fixes during the next 3 to 5 years using money that could be so well put towards the complete new rebuild. So I'm assuming that the response from the MLTC on March 18th was confirmation of the funding for the planning and design stage only. However, your report states that construction will start in summer 2022 with occupancy in the fall of 2023. Does that mean that the MLTC are covering all the costs for this 10-bed only project? Because if not, I don't believe that council has approved this total project as a capital expenditure yet. Meadowview Villa needs to be totally safe for the residents, and since the building is totally lacking in meeting the building codes, and timing is of the essence, I do not believe we should wait for a future MLTC call for development applications. Therefore, I will not be supporting staff recommendation E to table the budget motion. For the most cost-effective path forward, I'll be recommending that we approach the MLTC as soon as possible with a comprehensive shovel-ready development plan that seeks support for the redevelopment of the villa, independent of a formal funding program. Thank you.
Ms. Joris, would you like to respond to the question, please?
Yes, thank you, Warden Marriott, through you to Councillor Bird. The Dementia House project has been approved for 10-bed allocation. We're still working with the ministry about funding. We'll have to develop a development plan actually and negotiate with the ministry. In the September report, there was a pretty fulsome information about what the costs for capital would be and what we would expect to receive from the ministry. We do have some money in reserves, and we would expect that if the project is approved and funding is provided, that we would negotiate a mortgage, and then that would be, the mortgage payments would be paid by the structural compliance premium that we receive from the Ministry of Health. The ministry has not fully approved this project. However, the timelines that are in my report are also from the bed application. So there are still some things up in the air. There's no question about that.
So thank you. What happens then, per your report from last fall about the 10 versus the 10 beds? You said at the time you had 21 people, I believe, that were eligible for this kind of a facility. So, and I'm sure those numbers have gone up since then. But so, what is your plan for the rest of the people?
So the Dementia House is actually for people who are significantly underserved in traditional long-term care. So there were people at that time last summer when we did that review, 21 people that would meet the criteria for the Dementia House. We are providing those people with support along with extra support from Behaviour Supports Ontario, etc. But there are people that we have been unable to accept, people who we've had to discharge over the years, who we hope would be served better with this new model of care.
Thank you. Just one final question, please. So you mentioned that some parts of the building, although not up to the code and regulations, could be used for, as it is, they could be used for affordable housing. How many units do you think that it would be possible to make out of the parts of the building that would allow that?
Yes, I don't, through you, Warden, I don't know the answer to that question. I think that would be part of the review that we would do with this project going forward this year, to look at the building, to see what other uses it could be used for, as well as what kind of costs we would be looking at for some sort of renovation in that building.
Okay, thank you.
Councillor Weaver.
Yes, thank you, Warden Marriott. Just through the County Council, the statement was made that the Meadowview Villa is totally lacking code, and I guess I take exception to that. I think our homes are up to the standards that the ministry puts forth. I know they're inspected, and a statement like totally lacking is not. I'm disappointed because I don't believe that's the case at our homes. They're all being run excellently. So thank you. Just my comment.
Okay, Councillor Rumboats.
Yes, I just wanted to thank Jane Joris for this report. It was very good, very well done and very informative. And to add to that, I know our Watford Quality Care is adding an area in their home to help with patients specifically with dementia. And as well as a lot of the other independent homes are doing that as well, because there is a need for it. So there is other options for people with dementia to utilize within the county, and I support this recommendation.
Okay, one last comment from Councillor Bird.
Thank you, Warden Marriott. I would just, through the chair to Councillor Weaver, I would just like to clarify that there's no doubt that all the homes are being run the way they should or looked after. The comments were taken from staff reports to say that we're talking about the building code and regulations there, that building does not meet those from 1991 or in the current year. So obviously, going by the staff reports, there's a lot of things we have to do to fix before we can go forward, maintenance and all kinds of things. So that was what I was referring to.
Okay, we'll call Councillor Weaver. You want to comment?
The comment was made that it was totally, and that word is the one that we have. I'm sure there's issues with every building in the county that are not totally. So just my comment, sorry.
Okay, we'll call a question on the motion. All in favor? That's carried. Thank you.
Mr. Chair, can I just, a gentle reminder that you also have to ask who's in favor and who's opposed?
Yeah, I should have done that. I just, when I see a majority of hands, but okay, do you want to record it who's opposed to that?
I think this is a big decision. Like, it's moving forward. It's a big decision forward, and I'm certainly supportive. And I do think it should be recorded for the record, because anyone that's been involved in these type of projects know that there's a lot of second guessing and discussion as the projects unfold. So I'm going to ask for a recorded vote, and I'm pleased to vote in favor of this direction.
Okay, thank you for that. The reason I did not ask for opposed because I seen a majority of hands, but if you want a recorded vote, we'll go back that way. Ask Mr. Tifo to call the vote.
Thank you. So recorded vote requested by Councillor Bradley on the motion that's currently on the table, which is the recommendation set out in Jane George's report of today's date. And we will start with Councillor Bradley, and I have you as a yes.
That's correct.
Councillor Broad.
Yes.
I have you as a yes. Councillor Cook.
Yes.
I have you as a yes. Councillor Ferguson.
Yes.
I have you as a yes. Deputy Warden Hand.
Yes.
I have you as a yes. Councillor Loosley.
Yes.
I have you as a yes. Councillor Miller.
Yes.
I have you as a yes. Councillor Napper.
Yes, sir.
I have you as a yes. Councillor Rombos.
Yes.
I have you as a yes. Thank you. Councillor Stark.
Yes.
I have you as a yes. Councillor Veen.
Yes.
I have you as a yes. Councillor Weaver.
Yes.
I have you as a yes. Councillor White.
Yes.
I have you as a yes. Councillor Arnold.
Yes.
I have you as a yes. Councillor Bird.
No.
I have you as a no. Councillor Bushy.
Yes.
I have you as a yes. So the resolution carries 36-33. Oh, sorry, 34. 34-3.
It wasn't that close.
There's a reason I went to law school and nothing else.
Okay, here, throwing me off guard here. We're at number 13, committee minutes. Councillor Rombouts, please.
Yes, thank you, Warden Marriott. I present the committee AM minutes for February 3rd, 2021 for council's consideration.
Okay, so we have number 1 is correspondence received and filed. Number 2 is information reports. Reports requiring a motion.
Number 3 and number 4 on the next page.
number 3 and 4, and let's see here. Information reports number 5 and number 6. Reports requiring a motion number 7. Cultural services information reports number 8. And report requiring a motion number 9. Correspondence from Corporate Services Division. Correspondence from Member Municipalities, number 10. Information report number 11. And in camera, and number 12, adjournment. Councillor Rumboats.
I move that the committee AM minutes of February, is it 17th or 3rd? I'm thinking it's the 17th.
Yes, that's correct.
Yeah, okay. Be moved, or as read.
Seconded by Councillor Miller. All those in favor? Opposed? That's carried. Councillor White, please.
Thank you, Warden Marriott. I present the committee PM minutes of February 17th, 2021 for council's consideration.
Thank you. Under Long-Term Care Division, number 1, information reports, corporate services, correspondence from member municipalities, number 2, information report, number 3, finance facilities court division, number 4, report requiring a motion, number 5 and 6, Social Services Division, information reports number 7, in camera, and adjournment number 8. Councillor White, please.
Thank you, Warden Marriott. I move that the committee PM minutes of February 17th, 2021 be received and filed.
Seconded by Councillor Ferguson. All in favor? Opposed? That's carried. Moves us to number 14, items tabled from previous meetings. There are none.
Woodland hearings, please.
Oh, I'm sorry. I skipped the Woodland. Number C, 13C, Woodland hearings. That's myself, chaired that meeting. And let's see here. Yeah, we lost track here. We met March 16th. And we had one application that was approved as recommended.
Move to receive as information, Mr. Warden.
Yes, please. Moved by Councillor Arnold, second by Councillor Rumboats. All in favor? Opposed? That's carried. And no items tabled from previous meetings is number 14. So number 15, we have notice of motions. First one, Councillor Bird.
Thank you, Warden Marriott. So my motion is in the interests of efficiency, timing and inclusiveness, I move that A, immediately eliminate the AM and PM committee meetings, and B, have full county council meetings from January to November so that every single councillor has the important opportunity to weigh in on all topics, discussions and voting at the same meeting. If I can get a seconder, I'll explain some more.
Do we have a seconder for that motion?
I'll second that for discussion.
Okay, second by Councillor Rumboats.
Thank you. So separate AM and PM committee meetings have caused duplication as well as many long delays on decision making. We should manage our time and expertise well. All councillors should be present at the same time to discuss and vote on all topics. It's so important to hear what every councillor has to say before any motion is passed, and this could well affect the final outcome. With our current method of separate committees, i.e. only half of county council at any one time, some issues are voted on and passed without full council weighing in on the topic. Whereas if everyone heard the motion at the same time as well as the discussions would follow, and it may have an entirely different outcome. And I realise that, you know, the minutes of each of the committees come to the following full council meeting, but often because these issues have already been voted on, they may just get rubber stamped instead of opening up the dialogue again. Therefore, in the interest of improving our overall efficiency, timing and inclusiveness on the decision-making process, I move that we immediately eliminate the AM and PM committee meetings and also have full county council meetings from January to November, so that every single councillor has the important opportunity to weigh in on all topics, discussions and voting at the same meeting. And I'd like a recorded vote, please.
Any further discussion? Councillor Loosely.
Thank you, Warden Marriott. Just as a clarification in my mind, if one of the members from the other committee want to attend the other meeting, I know they cannot vote, but are they able to speak to the item? And it's just for my clarification.
Okay, I'll refer to Mr. Tifo for that.
Yeah, this question has come up probably twice before within the committee structure, and the practice of this committee, or sorry, of this council, has been that members of council can participate or attend, I should say, the other committee, and at discretion of the chair, participate in some of that discussion. But I suspect that given this committee structure, with the discretion of the chair, that participation will be fairly controlled and limited, so to speak. And of course, there's no entitled to vote on the other committee. So again, really 3 concepts, 3 points. So this is the 3rd time the questions come up. They can attend, a non-committee member can attend the committee itself. Secondly, with the discretion of the chair, or as the chair manages that meeting, they can participate, but they cannot vote.
Thank you.
Councillor Cook.
Yes, thank you. Just for the clarification, would this require that we'd only have 1 county meeting per month with this system, or would we be having 2 full county meetings based on what this proposed resolution would be?
I think Councillor, yeah, go ahead, Councillor Bird.
Thank you, Warden Marriott. Through the chair to Councillor Cook. So that was why I was had mentioned having meetings from January to November, because right now I think, if I'm correct, we don't have a meeting in January. So as long as we meet every month, then I think that would suffice, and everything should come to every full meeting that way. We wouldn't have any other breaks except for December, as we've done before. So that's just putting in an additional monthly meeting, and possibly one in the summer, depending how our schedule goes.
Okay, I have Deputy Warden Han, and then Councillor Rumbolds, and then Councillor Broad.
In my own municipality of Point Edward, we work on a committee system, and we find it expedient in order to work through some of the issues and the topics. And then we make sure that all relevant information is brought forward to full council at the next council meeting. And it is each councillor's responsibility to ensure that they're reading the minutes, and then all of the issues are discussed with full council, but we're reviewing the previous work that the committee has done.
Okay. Councillor Rumbolds.
Thank you, Warden Marriott. Just to add to Councillor Hand's comments, we also go through at every council meeting the minutes from the committee meetings. If there is an issue that I want to address from committee PM that I was unable to address during that specific meeting, I would then ask for that issue to be pulled out and discussed amongst all of county council, and leaving it open so that everyone has an opportunity to speak to every issue if it's needed. But those issues that I don't need to speak to, I'm comfortable with the people on committee PM dealing with those issues.
Okay, so we have Councillor Broad and then Councillor Bushi.
Thanks, Warden Marriott. I guess my question is maybe to staff or maybe to some of the councilors that's been around for a while. This used to be the way they did business, and then they moved to the AM/PM committees. And what was the rationale back then why they moved to where they are today? If someone could answer that, if not, that's fine.
Sure, somebody on council's been here long enough. I see Councillor Bradley unmuting his mic.
Councillor Arnold can go first.
Anybody like to tackle that?
Well, listen, if
Councillor
I
Arnold. Oh, sorry.
Go ahead.
Thanks, Warden. In the old days, and that's real old days, prior to Mayor Bradley being on council, we had a committee for everything you could do. And I think I was on either 11 or 12 committees and chaired 6 of them. And you talk about days at council. We spent days and days and days, and so it was compressed after the city came back into the county system and went and amalgamated a whole bunch of stuff, putting it together to make it a lot more expedient. And in those days, we used to get the budget book and go through a list of accounts, and to be able to pull them out and vote on them and discuss everything that cost $5 to $5 million. So you can imagine the time that was put on when we did the financial committee and some of the other things. So after the amalgamation, that my understanding was part of the package, we put these things together to make it a lot more expedient, and allowing individuals to have long conversations if they really felt needed to be done on independent issues at the committee level. So I'll turn that over to you again, Mr. Warden, and probably Mike wants to weigh in as well.
Thank you for that. Councilor Bradley?
Yeah, the only comment I'd make is there's been a great deal of reform over the years. I mean, there was 6 or 7 committees, and then, as Mayor Arnold remember, we had the executive committee, which was like the Vatican. It didn't matter what the rest of us did, the Vatican decided what we did. So we've come a long way, and I've seen a lot of good reforms. I have no difficulty with this motion. I think one reason civilization has not advanced is more meetings. That's what has held us back as a world. But I think it's not a bad motion. I would suggest, if there's support for doing it, that it needs to be phased in over a couple of months. That it needs, you just can't abruptly drop that system. There's things in motion at the committee level. So I would hope, if it is adopted, that we would bring it in place, say, for June or July.
Thank you.
Okay, Councilor Bushi, sorry, I haven't been ignoring you.
I was on the council when the same idea was tried, and we operated under that idea for I don't know how many months, until we realized that the meetings were much longer, very long, and the information wasn't coming the way we wanted it. So we went back to the old system, which we have now. So what I'm trying to say, we have tried the system and did not work.
Okay, Councilor White and Councilor Napper.
Thank you, Warden Marriott. Just to clarify with staff, because I've not felt the need to go back and look, we do broadcast every committee meeting now, and so my assumption is that the recordings of those meetings are available. Is that correct?
Good question.
I'll refer to Mr. Van Horn. I see him online. Could you respond to that, please?
I'm sorry, can you repeat the question again? We were having a sidebar conversation with respect to some of the history here with staff.
Sure. The question was whether or not the committee meetings that are broadcast now, the recordings are made available for everybody to review.
They are. Anybody can watch them at the time, and they can watch them after they stay on the online for the county. We did do a little bit of research just to remind ourselves and to maybe help council in the decision with respect to a committee system or not. The last time, as it's been commented on by several people, we did have at one point, I think, 7 committees plus the executive. And there was nothing but committee work that we went on. So it seemed, and it allowed council to, it got to the point where council was kind of getting into the day-to-day management of some of the operations, and because we were meeting so frequently. So council back in 2000 in the early 2000s, and then again in 2007 and 8, looked at the committee system. They've done it twice. In 2007, council decided to try to go to a system of a committee of the whole and then a council meeting. So we were meeting as a full group twice, but one of the two meetings was as a committee of the whole. It did not work out for a number of reasons, and one of them was that when you got everybody in the room together, and these aren't my words, these were the words of the councillors at the time, there was a handful of councillors who did most of the talking, and the rest of the council did not participate. They found this, and that part of that was because that it was too formal. They liked, council decided they liked the more informal nature of a committee system because it encouraged everybody to participate, not just people with strongly held views. So that was one reason why. The other reason why we looked at things back again in 2008, 7 and 8, I should say. We did a survey of some research about other counties in the province or other two-tiered systems, not necessarily just counties, I guess, but we found that in the rest of the province, when you had large councils, which we do, we have 17 councillors. When you have large councils, the vast majority of them operated under a committee system of some sort. And that was just to try to encourage people to get involved and to maybe become more subject matter experts almost in the smaller focus through the work of the committee. When you had smaller restructured counties, which with 7, 8, 9 councillors on them, as opposed to the 17, they tended to do away with the committee system, and they dealt with kind of meeting every 3 weeks or 4 weeks or whatever they did. So that part was out there. The other thing, and it's the more important point of what went through the report and the council consideration back in 2007 and 8. We have a committee system here, as I said, because in part we have 17 councillors, and you're trying to encourage participation. The other thing that happens is if what we do in our committee system is not a pure system in the sense that you get to carry your weighted vote into the committee system for voting. The committee system here is structured so that each councillor has a single vote. And the reason that was decided on and adopted by council was that they were trying to force or encourage consensus building when council was considering things. When you're at committee, if everybody has a single vote, you don't allow 2 or 3 people who have 3 weighted votes as opposed to single weighted votes to kind of ride or drive the agenda as much. So committee was set up to give everybody a single vote. There's no recorded votes in committee, it's single votes. And that by its nature encourages and hopefully builds consensus with people when they're looking at positions. So that was the kind of the background from the time.
Okay, thank you. Councillor White, you had a follow-up?
Yes, thanks. I was just going to finish by saying I do appreciate the intent of the motion. I find the system, as a first term county councillor, to work actually quite efficiently. I like, as Mr. Van Horn already pointed out, I like the rotation and the ability to somewhat take ownership of certain portfolios within the county. And that allows us to, I think, dive a little bit more deeply into the issues. And certainly pre-COVID, I found the structure of the meetings with the smaller group to just feel a little bit more informal and allow a little bit more generalized discussion without the tension, I believe, of having formal motions all the time. So that free flow of thought and discussion amongst my colleagues, I find incredibly valuable.
We have Councillor Napper and then Councillor Stark.
Yeah, thank you very much. I think my question was eloquently put by Mr. Van Horn there. I understood what he's saying this time around. I just had a couple of clarifications. Would we only be meeting once a month then? Or are we going to continue to meet twice a month? If we meet twice a month, we're just approving what we approve. So there's a lot of savings there. You could cut the payroll in half there, but I just don't understand it. And I think everybody, the system is now, if you see something on a committee, I know I've had success in changing their mind sometimes on the county floor. And it's just, I think it's been a good system and it's worked well, I think. But, there is merits to Councillor Bird's motion too.
Okay. Councillor Stark.
Yes, I will not be supporting the motion. I find that the committee system, imperfect as it is, and I would take some exception to Mr. Van Horn's characterization that it drives consensus. I'm not quite sure that it does that. Having said that, I do think it's the most efficient forum to generate discussion. And I think that really has proven itself at the committee level. So as such, I will not be supporting this motion.
Any further comments before we call the vote? Seeing none, I'll ask Mr. Tifo to take the recorded vote.
Yes, Councillor Bird has asked for a recorded vote on the motion that is currently on the table, which is the motion that you see at agenda item 15, paragraph A, subparagraph A, that County Council immediately eliminate the AM and PM committee meetings. And secondly, that Council will have full County Council meetings from January to November, so that every single councillor has the important opportunity to weigh in on all topics, discussions, and voting at the same meeting. So with the recorded vote, we will start with Councillor Loosely.
No.
Councillor Loosely, I have a no. Councillor Miller.
No.
Councillor Miller, I have a no. Councillor Napper.
No.
Councillor Napper, I have a no. Councillor Ronalds.
No.
Councillor Ronalds, I have a no. Councillor Stark.
No.
Councillor Stark, I have a no. Councillor Bean.
No.
Councillor Bean, I have a no. Councillor Weaver.
No.
Councillor Weaver, I have a no. Councillor White.
No.
Councillor White, I have a no. Councillor Arnold.
No.
Councillor Arnold, I have a no. Councillor Bird.
Yes.
Councillor Bird, I have a yes. Councillor Bushy.
No.
I have a no. Councillor Bushy. Councillor Bradley.
Yes.
I have a yes. Councillor Bradley. Councillor Broad.
No.
I have a no. Councillor Broad. Councillor Cook.
No.
Councillor Cook, I have a no. Councillor Ferguson.
No.
Councillor Ferguson, I have a no. Deputy Warden Hand.
No.
Deputy Warden Hand, I have a no. And Warden Marriott.
No.
I have a no. So the motion fails. 31-6.
Okay, item B is also notice of motion by Councillor Bird. Please go ahead.
Thank you, Warden Marriott. So my motion is, in the name of human survival, I'm asking for a resolution of council to instruct staff to write a letter to Premier Doug Ford with a copy to PM Trudeau by March the 29th. Sorry, I should have changed that by the following week, say April 19th, please. Asking that all the businesses and organisations, with no exceptions or restrictions at all, be fully opened up again immediately, as all businesses are essential to our domestic economy. If I can get a seconder, I will explain my rationale.
Is there a seconder for the motion?
A second for discussion.
Right, second by Councillor Bushy.
Thank you. So lockdowns do not work, or Sarnia Lambton wouldn't be in their fourth lockdown. This demonstrates the insanity of doing the same thing over and over and expecting different results. These government-imposed lockdowns have contributed to total economic suicide, sadness, isolation, distress, desperation, oppression, deprivation from celebratory occasions and grieving for losses, with a sharp increase in depression, suicides, domestic abuse, child abuse, divorce, addiction, general mental, emotional and physical deterioration, starvation and overdoses, along with greatly decreased financial incomes, loss of jobs, and in some cases, bankruptcy and loss of homes. Humans need to be socially interactive to thrive and survive. If people are succumbing to all these restrictions because they're scared of dying, then they're already not living. Viruses can be programmed viruses cannot be programmed to infect specific businesses, and yet the manner in which government-imposed restrictions have been applied is implying just that, with the closure of only certain businesses and others to a lesser extent or not at all. Such selectivity, when all should be treated equally in order to maintain their livelihoods that also sustain the municipal, provincial and federal tax accounts. A year ago, businesses spent lots of money on protective measures, so what was the point if they still cannot open? No government instruction will stop or change the direction of viruses. If left to their own devices, they will move through, travel on and dissipate, as all other varied viruses have done over the many centuries. No matter what the virus or infection, the same people will sadly be affected. Those who already have underlying health conditions, those with already compromised immune systems, and possibly, but not necessarily, the aged if the former health conditions apply to them. Our immune systems are incredible, with broad-spectrum antibodies well able to protect us from any virus, whether mutated or not. Before COVID, there were many groups, committees and hotlines in place to support those with addictions, depression, starvation and other devastating conditions that have so sadly befallen to our people in our community. However, since the onset of COVID, I haven't heard one word about any increased support to combat the increased trauma everywhere. The ministers of health are always talking about what we have to do to flatten the curve, but what are they all doing to flatten the curve of all the aforementioned 20+ scenarios? I guess really, if I think about it, it's hard to make a decision when it doesn't affect you personally. I mean, let's face it, career politicians haven't had to miss one single paycheck. And so unless something affects you personally, it's always very difficult to make a decision that affects everybody that lives in the community. So I believe we should allow Mother Nature to do what she does best by ending all lockdowns immediately and returning to the land of the living. Thank you, and I'm looking for a recorded vote.
Councillor Bushi.
I second the motion. I second the motion for discussion because over the Easter, our experience in our home was pretty serious. We tried to get in touch with our son and his wife. They're both doctors in the hospital in Barrie, and all we could hear, hello and goodbye. The doctor was struggling to look after the patients. They had no time for anything else. And at the time, people dying in their arms, and the arms of the nurses and the health profession. To my friend Margaret, this is not the time to suggest such emotion. With all respect, instead of going through with it, if you like, you can withdraw it. Withdraw the motion and move on.
Okay, we have Councillor Dean next.
Thank you, Warden. We've all suffered this year. And as much as I'd like to see everything open up, I think this is the worst motion that could happen. We have to stay strong. We have to support our medical doctors, and we just have to continue on and suck it up.
Did I see Councillor Stark with his hand up?
Yes, Mr. Warden, thank you. I guess I take some personal exception to the comment that local politicians don't have any personal experience. My brother died in 2020, and we are still waiting to bury his ashes because it has a direct impact on all individuals. Virtually everybody has had a personal experience that involves COVID-19. Now, he didn't pass away from COVID-19, but his death and his subsequent burial has been impacted. So when I hear advice being offered by medical officers of health across Ontario, Canada, the US, and as recently as today in Dr. Ranade when he answered one of my questions. I will most definitely be voting against this motion. Thank you.
Any other comments? Councillor Bird.
Thank you, Warden Marriott. Through the chair to Councillor Stark, I wasn't saying that nobody had any experiences. I wasn't even referring to that. I was just trying to point out to everybody, it's very easy to make a decision that affects the many when you're not going out without a paycheck, which so many of the businesses are doing right now with total closure. So it was to that point only that I am referring, nothing else. Thank you.
Councillor Weaver.
Yes, no, I'm disappointed that this motion came forward to this council. I think the province has brought, there was one statement made that there has been no additional support for people that are being affected. And I think there has been with homelessness, there has been with mental health issues. Our health units have been supported through the province with financial, and our staff have done a great job of making sure that we reached out to others and did our best. It's a tough time for everybody. I won't be supporting this motion. I think in the aspect that the lockdowns, I believe, do work. We don't know how many more numbers we would have, or more people would have died without the lockdown. So it's hard to say that they don't work. And I can't believe that this would be a very selfish motion to move forward and not respect those that have died from this by continuing on to do our best to try to control it. Thank you.
Councillor White.
Thank you, Warden Marriott. As at City Council, I will not be supporting this motion. I will recognize that there are elements of the lockdowns over the last year, as we've learned and grown through this, that do seem unjust and unfair. Certain industries seem to be taking the brunt of this. You know, there are parts of my life I've had to shut down for over a year now as well. So I sympathize with that. I understand it. And I believe very specifically for those industries affected, there should be more interventions by the government to try and assist with that reality. People losing their incomes, people not being able to afford their leases on their businesses and having to shut down permanently. So I'm very sympathetic to that. And I think there are lots of things that could have been done differently as these plans have rolled out. But as we heard this morning from Dr. Ranade, there's no consensus anywhere around the world as to how to do this. And I truly believe that when we depend on the medical professionals who are helping guide us all through this around the world, that's our best chance for survival as a whole. And that's what we really have to focus on here. If there are gaps in the system, then as we've done at City Council in Sarnia, we've done everything that we can to try and mitigate the effects of the lockdowns on our local businesses and on those within our jurisdiction, and affecting the things that we can affect within our limited superpowers. And I believe the county has also, and the county has received additional money to support vulnerable people and has done their best. We've done our best to try and support those folks as well. If there are gaps, again, let's address them. But ending all lockdowns without restrictions, that's the suicide. And that's unacceptable to me. Thank you.
So I'm going to give the final word to the mover. I think we had good discussion, and that's Councillor Bird.
Thank you, Warden Marriott. I certainly respect what's going on with everybody in the community. It's a very difficult situation. However, I still do not believe that we have enough scientific data to support what we're being told by our leaders currently. And since I'm an elected official and a voice for the community, I would like to just take this opportunity to finish up publicly by thanking everybody who's taken the time to write in support of my motion. So thank you very much to the entire community. Thank you.
Okay, I'll ask Mr. Tifo to call the recorded vote, please.
Yes, Recorded vote requested by Councillor Burr with respect to the notice or the motion that is in your materials at agenda item 15, paragraph B, and it's in bold. And we will start that with Councillor Miller.
No.
Councillor Miller, I have a no. Councillor Napper.
No.
Councillor Napper, I have a no. Councillor Ronboats.
Yes.
Councillor Ronboats, I have a yes. Councillor Stark.
No.
Councillor Stark, I have a no. Councillor Bean.
No.
Councillor Bean, I have a no. Councillor Weaver.
No.
Councillor Weaver, I have a no. Councillor White.
No.
Councillor White, I have a no. Councillor Arnold.
No.
Arnold, I have a no. Councillor Bird.
Yes.
Councillor Bird, I have a yes. Councillor Bushy.
No.
Councillor Bushy, I have a no. Councillor Bradley. I have a no. Councillor Bradley, correct? You're on mute. I have a no. Councillor Broad.
No.
Councillor Broad, I have a no. Councillor Cook.
No.
Councillor Cook, I have a no. Councillor Ferguson.
No.
Councillor Ferguson, I have a no. Deputy Warden Hand.
No.
Deputy Warden Hand, I have a no. Councillor Loosely.
No.
Councillor Loosely, I have a no. And Warden Marriott.
No.
I have a no. So the motion fails. So 32-5.
Okay, that brings us to item 16, other business. Any other business before this group today? Seeing none. Number 17, notice of bylaws, please.
Yes, it is moved by Councillor White and seconded by Councillor Bushy that bylaws 5 and 6 of 2021 as circulated be taken as read a first and second time.
Moved by, sorry. All in favor? Opposed? That's carried.
Is moved by Councillor Bushy and seconded by Councillor White that bylaws 5 and 6 of 2021 as circulated be taken as read a third and final time.
All those in favor? Opposed? That's carried. That brings us to adjournment. Moved by Councillor Napper. Seconded by, Councillor Napper, do you want to say something, or was that the mover? Were you moving that?
No, let's just get out of here.
Okay, seconded by Councillor Loosely. All in favor? It's carried. Thank you. We'll see you on May the 5th.
Stay safe, everybody.